Hello, and thank you all for your time. My name is Hailey Ferguson. I am the Director of Development at SHOTS Tulsa, and I am also the Director of Programs at the Oklahoma Harm Reduction Alliance. And we are really excited to be here with you all today to discuss some of the challenges that our programs have experienced during COVID-19, and we're excited to talk about what we do going forward.
Great. So why don't I start with you, Hailey, since you're right here. I'll put you on the spot. What were some of the major challenges that SHOTS has faced over the year of the COVID pandemic?
Well, thank you for asking that. Some of the biggest challenges that we've had at SHOTS is the fact that we're not really able to see participants face to face. And our participants really relied on us to be that one person in their lives, to be that smile, to be that warm, compassionate person that cared about them. And a lot of our folks do not have access to technology, to cell phones, and so we're not able to stay in contact. Additionally, the need for naloxone has grown exponentially. So thankfully, we have a program to do that. And then some other things that have been a struggle for us is keeping that volunteer momentum online, because again, we can't see people face to face. So it's been a struggle to try to keep that momentum going in COVID-19.
Tamara, can you describe what some of the challenges are that you've had in the Bronx?
So I would say that the challenges of harm reduction with the folks in the communities that we serve and that we live in as Bronx Moving are the same challenges that existed before the pandemic, being unsheltered, homeless. These are folks who use drugs actively, so the criminal justice system and the impact on our communities, all of those existed. I think COVID-19 exacerbated or brought to our forefront the fragility of the social services sector, so that a lot of agencies and community-based organizations where folks could go to grab a shower, to grab a hot meal, to access syringe services and harm reduction and case management essentially disappeared in March, April, May, June at the height of that first wave. And so the fragility of the system was revealed exponentially. And our program, in some ways, what was proven was that a mobile program where you literally, physically, temporarily, geographically meet people where they're at, in the harm reduction sense of the pillar, but also where you take the services to them, became life-saving, especially when everything else closed down.
That's really fascinating. And I think one of the things everyone's starting to realize is how the COVID pandemic didn't change all of the other issues. It mostly amplified them, if anything.
Yes.
Clayton, how have things been in Philadelphia? What were the challenge you guys faced there?
I think similar to other folks who have spoken, I would definitely amplify that, the services have been not given to participants, the issues that the participants, guests, clients, however we term, the folks that we work with and work for have not received before COVID, only got, exploited and exploded, when COVID started. So, I mean, fortunately, we have a staff that and leadership that understands that, our participants are in much shakier ground than we have been, or we are in general. And so we work to remain open. We did not close our doors throughout the pandemic, starting early March to this day. Obviously, there's some services initially that got shut down for a couple of months, and we were doing most of our work either from our doorway or on our small street on the side of our building. But programs like testing, not testing, syringe services, overdose prevention, meal services, safer sex kits, mail services. These were deemed essential and remained functional during COVID. We were able to secure a lot of PPE, which we obviously use for ourselves, but also give out to our participants. And slowly, I want to say starting in July or so, we started adding additional programs to our format. But so we're pretty much at, I would want to say, about 80% of our regular format. There are some external service providers who have not come back either at all or as regularly as they used to. But our core services have remained intact because we just know that the folks that we're working with and working for have a lot more going against us. And as long as we, are doing as best as we can to observe social distancing, mask wearing, glove wearing when it's applicable, and other higher levels of PPE when it's applicable. We've, been pretty great at not contracting, COVID-19, as a staff, as well as also have not reported a lot of cases for those participants who are testing. And then we've, started a program like a meal site that's serving about 550 to 700 people daily, Monday through Friday. That's also been a gateway to other services, including COVID testing, typically on a weekly basis. So definitely been a challenge. I always say personally, it's like living a dream in a nightmare because you're happy to be working, happy to be serving people. But obviously, it's a very challenging time, but certainly proud that as an organization, staff has been continuing to come in, even, in flexible scheduling and been able to serve the people, as face-to-face as possible in a pandemic.
That's just remarkable. Susan, how about in Alabama?
Well, I concur with a lot of the issues that the other facilities are having. Alabama has a face mask rule, but our patients and a lot of Alabamians struggle to wear it, which scares the staff. I had COVID in December, and we take every precaution we can. We have the foggers and we mandate if a patient comes in the building, they have to wear a face mask. And oftentimes we have to give it to them every day, even though, we gave it to them the day before. Some sad kind of things. So the health department was giving out condoms, and they have stopped. So we haven't gotten that. We have a high rate of STDs in Alabama. In 2013, our capital city had the highest rate of STDs, and we know that can create havoc. We also, AIDS Alabama was testing our patients on a regular basis twice a year, and almost everything they do is by Zoom now. And so they haven't been able to come out and test. And for us to do the testing of HIV, it's about $130, $150. Patients don't have that kind of money. So, we're really putting Alabama at a worse risk when we already rank pretty much 49th and 50th in all areas of health. So it's been pretty bad.
That's another example of the types of issues that didn't go away just because COVID was in the foreground. Mm-hmm. I know that some of you have prepared some slides, so maybe Susan, will start with you, and I think Rima will put the slides up. So
I'll just kind of move through fast. The first one was about introduction, and so we can skip on through that. You can skip on through that. That's my introduction. So an interesting fact and a couple of tidbits about Alabama is we are ranked number one in football. We are national championships. We got that down pat. But we don't have a lot more at all. We ranked 49th and 50th, like I said, in many areas. Interesting is 2012, 13, 14, 15, 16, 17, 18, and 19, we wrote the most opioid prescriptions per capita. Well, I used to brag about that when I gave talks, and I was excited. I said, so we're doing something right. Well, West Virginia is the one who has the most deaths. Well, then Auburn University put out a research that says Alabama is actually the worst in reporting opioid overdoses. So then, I have to back up on that. So knowing that Alabama ranks so bad in healthcare, we're constantly trying to help the patient, see what we can do. We mainly battle the good old boys of Alabama. They want to stick their head in the sand and say, okay, well, if you got HIV or you got hepatitis, it's your fault. We can go to the next slide. There we go. Okay. So a little bit about medication-assisted treatment, methadone treatment facilities. Methadone is one of the most researched medications there is in the United States. Methadone treatment facilities are actually known as one of the most medically regulated facilities in the United States. We are more regulated than a hospital. And SAMHSA about 5 years ago published that we're more regulated than a nuclear power plant. So we have all of these barriers, mainly because of stigma of having to do these regulations. And so like right now during COVID, that really creates a lot of havoc for us, that we're having to do things that we feel like are not necessary, but to maintain and stay open. Every methadone treatment center in the United States, they're required to be federally accredited, just like Joint Commission, CARF. So we have a lot of work that we have to do every day, no matter what. We can go to the next slide. So if you close your eyes for a minute, or if you think for a minute, what does a methadone treatment facility look like? And think about it just for a second, and then open your eyes and go to the next slide. Most people think that we're backwoods. Knock on the door. I've got some methadone. And actually we're not. And you'll see in the next slide that we're actually a medical facility. We're clean, we have a lot of guidelines, and we want to make it that way so the patients feel comfortable coming in. They already have a lot of problems. The patients all have opioid use disorder, but secondary, they can have cocaine use disorder, benzodiazepine, they can have an array, plus they can be homeless. They have so many things. And right now with COVID, it increases because family members are dying, and then the stigma. Local hospitals don't want you to come at all unless you're pretty much about to die. So all of this is actually, you can go to the next one, has wreaked a lot of havoc. A typical patient that we have, 97% are Caucasian, about 0.3% are positive for HIV. Our biggest infectious disease is hepatitis C. We have a huge problem with patients reusing needles. Very often during intake, a patient will come in like this picture and have a broken needle in their arm for reusing. We desperately need a needle exchange. But when patients come in, they get initial physical, they get annual physicals. And right now our nurses, they're rushing through because they don't want to be next to the patient, because a lot of times these people have not protected themselves from COVID. When I had COVID in December, Wednesday morning, right before Christmas, I tested negative. I felt bad. My partner, a psychiatrist, had told me he tested positive. Well, around, 8 hours later, I showed positive for COVID. So even when we test patients, and our state is great about giving us the COVID test, when we test, we don't know if they actually can or have it, because, hours later I had it, and they could have it too. You can go to the next one. The longer a patient stays in treatment, the less likely that they will contract or get HIV or hepatitis next. You can do the next slide. And comparing HIV patients in Alabama, and the United States, it's pretty much the same parallel. There's some interesting facts and research in Alabama. You can go to the next one. So even though we're parallel, and you can see on here, the highest rate is men having sex with men. And in Alabama, they say we are 50%. In the United States, is about 79%. But if you look at the bottom of Alabama, they say about 23% is undetermined. Well, I think that that's a barrier where they really don't get very thorough with the patient or with the person in Alabama. We have a lot of stigma, a lot of good old boys, and people just flat out aren't going to say what they've done. And it's pretty sad, but in all the others, we are parallel. And I think we're matched them. It's just Alabama says undetermined in the next slide. So as I said, medication-assisted treatment facilities get COVID tests, and we do initial physicals. We are, as others are doing, most of our communication is through Zoom. And a barrier is if a patient is driving or if a patient is home and family members are standing behind them and they can't, be confidential. As I said with the needles in the arms before, a patient may be not using opioids and we're doing drug screens, but when you're sitting with them, oftentimes you can see fresh needle marks, which may be with cocaine or it may be with meth. We have a severe problem with meth in Alabama, and because of a lot of the job losses due to COVID, meth sales, it has skyrocketed, and a huge percent of our patient has meth. We rank 14 in the positive COVID tests in the United States and 10 in the deaths. We can go to the next one, next slide. So one thing that I really try to do, because we can't necessarily be with the patient, if you look at my little skeleton, we'll try to put something that catches a patient's eye when they come in, because everybody's got to come get their medication. In the United States, SAMHSA has reduced the amount of times a patient has to come in and get their medication if they're methadone only, or if they're not really doing high risk behavior. But we still put out posters or just something to grab their attention. And, I'll put a big Superman and hang it from the ceiling. And before we wouldn't have done that, but just anything to get their attention. We're not doing our groups. I don't know what to do with the condoms. And the condoms are actually not even getting shipped to the health department because I would go get them. So we're struggling so much more with these ways. One thing that I want to say is, and the reason why I put out the national championship is Nick Saban has some really good mottos. And I think that it's a motto that I take every day, because one part of my life is I do help people, volunteer for years in Children's Hospital, etc., is that you want to be a champion, and everything that you do, you want to be the champion in what you do. And I think that's what helps the football team, because they have these mottos and these strengths. And we've got to reduce some of these biases and step out and just try to think out of the box right now to help these patients. So I think that's it. I think at the back I put some referrals or contact me just to kind of move on. But it's just so important that we think out of the box right now. And if we have to go outside, I'll go outside and meet a patient, and we'll sit across chairs in the parking lot in the back of it, just to any way we can. Alabama has warmer weather, but it's impacted us, and I really worry of not having condoms here. I worry about people not getting tested, and the physicals being reduced, and patients not getting the services hands-on. And I think that's what's prevented us from having a lot of trouble in the past. But I think we're about to have some really serious issues.
Thanks, Susan. That was a great presentation. Just one clarification. Does Alabama not have any syringe exchange programs?
Let me tell you, that is like my pet peeve. And I serve on the Governor's Council, as I said, and I'm constantly fighting for that. Some of the leaders in the health department have tried, and I present this every Governor's Council meeting. But there's so many people that think if we give out condoms or if we give out needles, we're saying that it's okay. And the cost for hepatitis treatment, whether they have Medicaid or, whether the companies help fund it, that's $50,000, $60,000. It's just crazy of how much work I'm trying to do to pass the needle exchange. And I guess when Andrea said something about her needle exchange, I wrote her name down to try to help us. But it is the good old boys and the politicians that think, just with all the research, the American Medical Association, everybody says, get needles, bring needles. And I'm just the woman that is trying to bring more addiction drugs in Alabama, is what they say. So, well, any help I would love. Any help, we would love that.
To the choir here, certainly.
Yes, yeah.
Let's move on a little bit. Tamara, can you go through your slides? I think Rima will put them up.
Absolutely. So let me start off by saying that my slides are bilingual. They're both in Spanish and English, because part of our challenge within the harm reduction movement in the US is how do we diversify language so that English is not always centered. So again, that's why a lot of my slides are bilingual. And basically, Bronx Moving is a project of love. It was created with the idea that we need to center communities with its linguistic and cultural beauties with direct harm reduction services. Next slide, please. And the vision is for Bronx Mobile is that we really believe that harm reduction as both a practice, public health practice, and a philosophy that centers social justice needs to be 24 hours a day and 7 days a week. And then in fact, harm reduction started by and for people who use drugs, but it has been commodified within the capitalist system. And in many ways, programs that started grassroots on the streets, led by community members, for community members, have become much more 9 to 5, Monday through Friday. And as a public health educator who has been at the forefront of harm reduction, I saw that shift happen. And along with the co-founders, Alexis Del Rio and Nelson Gonzalez, we have been talking about it for a long time. And then in 2018, we decided to actually hit the streets at night and on weekends when we knew that a lot of harm reduction agencies either were closed or had limited services. Next slide, please. So what's happening in the Bronx? And I understand that there's a lot of folks on the call, on the training that are from the Bronx, from Fordham University. So you're gonna recognize a lot of the geographic markers and maps that I'm gonna share. But the Bronx is a milieu of the US where you have poverty, racism, social inequity, ableism, classism, sexism, transphobia, all coming together, right? And with COVID-19, the conversation has been that COVID-19 is the latest example of the social determinants of health. But essentially what we're seeing in the Bronx is when you look at oppression and all the different isms, we're having a direct impact on the health and wellness of people who live in the Bronx and all of its diversity. So it's impacting Black Americans, Puerto Ricans, migrants, and queer folks in different ways. And the effect is in fact exponential. You're not only impacting the health indicators, but you're also impacting access to preventive health services, access to HIV/AIDS services. In fact, we believe within Bronx Marine that poverty and oppression violate human rights and the dignity of human beings. So that's kind of like our mission, our vision, and why we do the work that we do. Next slide, please. So the Bronx, and this is just an example of the routes that we utilize. Bronx Mobile is in Spanish and in English, but let's say most of our services are in Spanish when we hit the streets. It's mobile. We don't have a site per se. We literally rent a zip car and on weekends hit the streets. We hit the streets when we know that fixed site syringe services providers are closed or have limited services. Next slide, please. So why the Bronx? Why the Bronx? So we've already talked about the isms and how they come together around power, privilege, and oppression. And one of the health indicators that we look at is the opioid overdose crisis. And so again, this is the same information in Spanish and English. But pre-pandemic, we have some data. And in fact, we see that in New York City, there's been a sharp increase on opioid-related drug overdoses. But that's concentrated in the Bronx. It's the highest across all boroughs. And we know that with fentanyl being in the drug supply chain, that in fact, overdose fatalities have increased. Next slide, please. So again, this is just a quick map of New York City for folks who are outside of the region. But we can look at this. This is basically looking at unintentional drugs, poisoning deaths in the neighborhood, basically the overdoses. And the darkest blues are where you have the highest rates. The island to the bottom left, that's Staten Island. And then on top are regions of the Bronx that are highly impacted. So again, we wanted to show you what does this look like within the city, and how in fact the city is very heterogeneous, and that you have to look deeper at the data in order to unpack it and be able to create programs that are tailored and meet the community needs. Next slide, please. So again, we talked about the ism, right? So if we're going to talk about drug overdose deaths and the opioid crisis, we also need to talk about poverty. These are linked, right? And so again, you have portions of Staten Island and Brooklyn and Queens, but look at the top. That's the Bronx again. Next slide, please. So what I would say really quickly before I go into gentrification is that if we were to replicate or put another map, a third map of COVID-19, guess what? It would match the poverty rate. And it would also match asthma and diabetes and HIV/AIDS. So, you know, when we look at these health conditions, diseases, yeah, it's in Spanish. Don't worry, Janine. I'm going to translate it in a little bit. Essentially, we need to look at how poverty is deeply linked to health and experiences of health. So what this slide in Spanish says, and I'll translate it really quickly, is that we utilize maps as an instrument of documenting our work, but also the necessities of the participants. What we do when we hit the streets is that we have Google Maps running. So we're documenting literally where we're stopping along the way. And that is matched with anonymous data on what it is that we're seeing. Folks encountered types of substances that are being used, whether they are unhoused, unsheltered. And we basically, in real time, are documenting not just our harm reduction provisions, but also what are the needs that New York City, New Yorkers that are unhoused are experiencing in the moment. We are seeing that the Not in My Backyard movement has actually become greater during the pandemic. We are seeing our participants being pushed out of communities left and right. And in fact, all you have to do is look at mainstream media to look at all the reports of the hotels on the Upper West Side where people are being pushed out because those became temporary shelters. When you look at the subway system, which used to be 24/7 pre-pandemic, and how it closed overnight, that literally was an eviction for our participants that has been deeply felt over the winter months. For many of our participants, the subways is where they would go shelter at night and spend the night. That is no longer available. And so when we look at gentrification, I think the response of a Bronx Mobile and what a lot of harm reduction service agencies need to do is become more flexible in terms of geography and the method of the provision of services. We need to be able to move literally where people where they're at. And next slide, please. And what I'll say with this really quickly is one of the pillars of harm reduction is meeting people where they're at. And usually that refers to kind of like the mental health, stages of change, etc. But with Bronx Mobile, we actually want to challenge ourselves within the harm reduction movement to say meeting people where they're at is also about taking the privilege of being able to access, walk to, catch a bus, catch a subway to where the agency is located. For people who are poor, who cannot afford a meal, having them to catch a train, requiring them to come to us is actually a privilege. And so we need to really examine how we change the provision so that we go to them. So the next set of slides are examples of the kind of routes that we have taken. And again, for people from Fordham, you're going to recognize a lot of these places up here. But this is just an example of the kind of routes that are centered in where the opioid overdose crisis is happening in the Bronx, and also matches the rates of poverty, and in fact also match COVID-19. Next slide, please. So yeah, this is the repeat. Next one, please. Sorry about that. And this is a walkabout. So we don't just provide what we call rightabouts, which is using the vehicle. We also walk the neighborhoods where the different Bronx Mobile co-founders and volunteers live in. So it's about getting to know your neighbors. It's about walking, assessing what is needed, and then mobilizing as required. Next slide, please. And this is the last one, and this one is bilingual. So, when we talk about how do we center our communities, this was true pre-pandemic, and it is certainly true now that we're in the middle of COVID-19. We need to be able to center language as something that is critically important within harm reduction. All harm reduction services need to be culturally centered and linguistically appropriate. Leadership must be by and for the community. We need to center people who use drugs as the leaders of what is needed, what, where, what, why, when, how, and we need to hire them. We need to be able to hire them within our agencies to do the work. The third bullet is what I've already shared, that meeting people where they're at must be in real time, and it must be geographic, emotional, mental health. Harm reduction must address systemic change policies and procedures. I cannot emphasize this enough. The opioid overdose crisis exists, but it's because of the isms that exist in our society. They're all related. There must be housing that is safe, secure, and affordable. The challenges that we, our participants, face in Bronx moving are around poverty and housing security. Everything else, in some ways, is incidental. And until we, or it's a Band-Aid, it's a Band-Aid, right? Until we're able to give them the housing and the economic security needed in order to lead healthy lives, everything else we do is going to be a Band-Aid. Sorry to say that. And I say this as somebody who does the work, but systemic change is fundamental. And that systemic change must be accompanied by physical and mental health program provision. And I just want to emphasize that one of the things that I have seen, we have seen in Bronx Mobile since the pandemic hit, is the importance of mutual aid. Mutual aid networks and support kept us in Bronx Mobile alive and have kept many community members thriving and healthier in ways, and that the system failed during the pandemic. Again, the social services infrastructure failed tremendously, and mutual aid networks that existed pre-pandemic basically became amplified during COVID-19. And last but not least, a fundamental within harm reduction is that the participants get to decide the process, the goals, and they must be part of the process of the leadership. And we do this in Bronx Mobile by centering the community and meeting people where they're at in real time, linguistically and culturally. That's the end of the slides. I'll end with this. We have a need. There's a need to impact the data. And I think it's part of the challenge of epidemiology. The data, for example, for Latinx or Hispanic communities assumes that by being Spanish-centered is sufficient. But when you look at the Hispanic overdose crisis among Latinx communities, it is Puerto Rican people who are being impacted the most, at least in the Bronx and New York City. And so the intervention, it is not sufficient for you to just be in Spanish. It's about looking at the history of colonialism, at the history of migration, the air bridge, and then developing programs and services that make sense for the communities that are greatly impacted. And with that, I will end. Thank you.
Thank you so much, Tamara. That was so much amazing information. Clayton, can we go through your slides?
So, yeah, for those who don't know, we can go to the next slide. Prevention Point is known as PPP in this area. There's a Prevention Point Pittsburgh, which is obviously about 5 to 6 hours cross state on the west side of Pennsylvania. Both those two prevention points are not wholly affiliated, but work on statewide issues. They are two of the only legal syringe services programs in the state of Pennsylvania. State of Pennsylvania is very large. There are towns like the state capital, Harrisburg, there's Reading, there's Scranton, there's Wilkes-Barre, there's Erie, Johnstown, Altona, State College, and many, many more places. Some places do have underground exchanges, but as far as legal syringe services, they're only coming out of two places right now, and that's Philadelphia and Pittsburgh. I think there is a lot to be desired, obviously. We're one of two states on the Eastern Seaboard that does not have legal syringe access. The other is South Carolina. And obviously, we are the only one in the Northeast Corridor as far as states go that doesn't have legal syringe services throughout the state. So, you know, despite the success that we have as a city with Prevention Point and the services, definitely still have stigma and judgment, both on the federal side, certainly in the state, as well as in the city. And I agree with Tamara that there's a lot of not in my backyard mentality that plagues the services that we're able to provide, even though, you know, we definitely have a lot of services to be proud of. That being said, we are a nonprofit public health organization committed to promoting health empowerment and safety for communities affected by drug use and poverty. Next slide. We've been around since 1992 and have been on the front lines ever since. Unlike, I say, Pittsburgh in Pennsylvania, that was approved by the, you know, Pittsburgh, like City Council in Allegheny County. We are made legal by a executive order from the mayor of Philadelphia at the time, who was Ed Rendell, and he made an executive order because of the new cases of HIV in the city in the previous year, which was 1991. 48.5% of them were attributed to people who were injecting drugs. So he made an executive order that made what people were already starting to do illegally legal in Philadelphia and in Philadelphia County, which is synonymous with each other. And we've continued to be legal via that executive order ever since. There's always been talk about trying to get approved through City Council, but it's kind of like trying to wake up a sleeping beast. Because I'm not in my backyard, there's a lot of folks who, despite the effectiveness of our program, would not approve of City Council-wise it being approved. So as long as we're able to make the change that we have without City Council approval, it's never been tremendously important that we tackle it on that level. In fact, it might bring more eyes to the circumstances that we might not want to see. So that's telling you still how far we have to go in the city, and you know how even some folks still give us a hard time. To answer the question that was on the board, our syringe protocol, and you can go to the next slide. Our syringe protocol is 1-for-1 after 50. If folks bring nothing, they get 10 syringes. After 50, it's a 1-for-1 exchange. We never want to deny someone on the days that we have syringe services accessible. You know, if they didn't bring anything back, to get absolutely nothing, because obviously that would thwart the public health of what we do. So we have everything is plus 10 up to 50. And then after 50, it's a 1-for-1. Moving on to the vision, basically, we know that each and every individual is valuable that we work with and work for. And so we try to treat people with the same, you know, values, which is a non-judgmental stance, respect, trust, you know, knowing that folks have individual responsibility, but we have a shared responsibility to each other. And we encourage and support individuals around self-determination and self-empowerment. We know that we have to be advocates for folks on the macro level as well as the micro level. We know that flexibility in services and times are really big. And so we've always tried to have flexible services. It's definitely been a gateway to services being accessed by folks. And we know that we have to be transparent, always keep our ears and eyes to the ground, take suggestions from the people we work with and work for, as well as other key community members. Next slide. We want to do our services always in the baseline of providing safety. We do have a medication-assisted treatment program in-house. We refer people more than any other external organization outside the city to treatment options. But at the baseline, we are not a drug and alcohol treatment program. We are a harm reduction organization that wants folks to do what they're doing as safely as possible. And we provide those services and those materials and the staffing to help do that. And that includes making sure that we greet people in a welcoming and inclusive manner, that we strive to be non-judgmental, that we meet people where they are, that we respect every individual, that we promote human rights, and we contribute towards advancing social and economic justice. Next slide. Basically, our goals are to, like many people on this call, reduce the rates of HIV and hepatitis, particularly Hep A, B, and C, to be a source of information for folks around reducing risk and harm. We want to help reduce and stabilize STIs, along with, HIV and Hep C, and as we get bigger, other medical concerns, which we're starting to treat. We want to be a source of a bridge to medical care, a bridge to housing services, and a bridge to treatment-related services as well. Next slide. And basically, as all of you know, we do all of this under a harm reduction guise. There are many, many definitions of harm reduction. The one I use so frequently is a set of practical public health strategies designed to reduce negative consequences of risky behaviors, which include drug use and sex work, and promote healthy individuals and community without, and it's italicized for a reason, without necessarily reducing drug use. Once again, it's around empowerment and self-determination. We know that abstinence-only model has not worked, will not work for everyone. We believe in reduction of harm. We believe in folks having what they need to do things safely so they can have that motivational moment. For the folks that are abstinent-only bent, you cannot recover if you're dead, and you likely will not recover, in a way that is productive to you if you know that now you have a life-changing or life-threatening disease. So if we have the means to stop someone from contracting disease, not only can stop them from contracting disease, but save, millions of dollars, and that's something that we should do. And we believe that on the personal level and also on the financial level. What we do has been working here like it's been working every place that's been implemented. Next slide. We know that, the key principles of harm reduction are definitely to design, promote public health interventions that minimize harmful effects of risky behaviors. Understand that all those risky behaviors are complex, they're multifaceted, and they're issues that encompass regular use to total abstinence. Meeting people where they are is a really big deal in the work that we do, and making sure that the folks who are actually doing the activities and the people around them are the primary agents of change. Next slide. We know that people gravitate towards doing activities because of poverty, class, racism, social isolation, past trauma, sexually based discrimination, and more. And that, makes people gravitate towards doing a lot of the activities. It also affects people's vulnerability to and capacity for effectively dealing with what these risky behaviors bring to the table and more and their harms. I think the great thing about harm reduction, as I'm sure everyone in the call knows, is that we don't, work to, be, a cherry pie in the sky as far as reality goes, but we also don't browbeat people around what they're doing. We want to be welcoming. We want to have an open door policy at all times. We know that's a gateway to folks getting the help that they need. And we definitely want to be a safe and humane alternative to the war on drugs, because we know the war on drugs has been a war on people, particularly gender minorities, particularly people of color, and people living in poverty. Next slide. This is just a quote that I think is pretty poignant from John Auerkman, who was Richard Nixon's domestic policy chief. And basically, he just says, you want to know what this is really all about? The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or blacks, but by getting the public to associate the hippies with marijuana and the blacks with heroin, and then criminalizing both heavily, we could disrupt those communities, arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. Next slide. Basically, our programming is non-judgmental and low threshold. We do safer injection kits as well as safer smoking kits. We do wound care supplies. We do safer sex supplies, medical supports, legal supports, and social supports. Like I mentioned earlier, these services are happening a lot more mobile. We do mobile sites for our syringe services, as well as our wound care kits, safer sex kits. We do a lot of our work outside of our doors, as well as on our small street next to our main building. We do let people in, particularly for medical appointments and case management. And on days that are really cold, we have warming centers where folks can come in for 23 to 24 hours, socially distanced and masked up. Next slide. Goals of harm reduction, prevent disease, reduce mortality, treatment for drug use, and empowering participants, communities, and reduce stigma. Next slide. Our leadership team, we have folks with professional degrees and folks with street degrees, folks that have worked in HIV and hepatitis and drug and alcohol treatment, and folks that have been a part of those systems and now are working with us and provide a certain guise and a certain level of experience that we definitely need working with all the people that we do. Next slide. Our syringe service is still operating. We do now we do more like 13 weekly exchange or access sites. They're both in our building in Kensington, also mobile throughout the city, Monday through Saturday. We don't force participants to receive other services, but certainly want them to know that we do more than just syringe services, and we always bring other social service resources to the community. Next slide. We have worked hard to reduce new cases of HIV attributed to intravenous drug use. It was at 48.5% in 91. We opened up in 92. And you would see as the years have gone by, in general, we've dropped the numbers significantly. When you're looking at 2018, you recognize that the presence of fentanyl started to enter the drug supply, and we saw a major spike in the amount of new cases of HIV attributed to the intravenous drug using community, which is why if you look at the bottom numbers, yes, there are active paid workers at syringe service program. If you look at the bottom number, as far as the millions of syringes given out, we are the country's largest syringe service program by volume of syringes to thwart the fentanyl, which is 20 to 100 times more potent than an opioid pain pill or a bag of heroin, and yet stays in your body less often. So if you're someone who injects, you would probably have to double to triple up the amount of heroin or syringes you would use if you're using fentanyl compared to when you used to use heroin, 2017, we were kind of caught slipping in part because of community pressure to lessen the amount of syringes we give out. Therefore, we made sure that we with as much syringes as needed to reduce the HIV rates. Next slide. You can go to the next slide. We know that the cost of prevention is a lot cheaper than being reactive. We say 8 to 10 cents for, a syringe. We say $3 to $5 for the syringe, 10 syringes and supplies that we give out, as compared to HIV and Hep C, which is at the least 5 figures for Hep C to get cured and could be reoccurring. For HIV and the medication and treatment, you're talking about 6 figures to 7 figures. Next slide. Basically, this is a cherry on top of that argument Sunday. George Washington University did a study, 10 years, they estimated that Prevention Point Philadelphia, or Philadelphia having a syringe service program, basically saved about 10,592 cases of HIV in Philadelphia in a 10-year period. And basically, they estimated that someone contracting HIV would be about $230,000 for medication and treatment over a lifetime. If you did the 10,593 people who had to get HIV treatment, that basically be about $2.4 billion over 10 years that saved, or $240 million annually that saved because of having a syringe service program. Next slide. We do HIV and Hep C testing, confirmatory blood draws, and linkage to care for HIV and Hep C and drug treatment referrals. Next slide. We have a drop-in center that's a major source of people engaging services. When we were closed for COVID, a lot of folks had to spread out and could not come into our building. And you saw a lot of those folks not get linked to services and wind up being in places that many people in the community don't want them to be. But they also, even pre-COVID and probably post-COVID, have a major issue with folks, having services. They want the services to be in the areas where there's not the, epidemic or the crisis, not realizing that basically denying people access to services doesn't mean people are going to stop using drugs or doing risky behaviors. They definitely are going to continue to do so, and they're going to continue to stay in the neighborhoods, and they're going to continue to have negative health outcomes. It's really mind backwards to assume that because you deny someone access to resources, it means things are going to get better. We've seen that for generations with the war on drugs. It has not worked. Next slide. We do a PrEP clinic. You can go to the next slide. I'm just going to run through these. I know I'm timed out. Our overdose prevention kits, we've given out over 20,000 in the last 2 years. We do MAT inductions. We do mobile outreach with them. You can go to the next slide. We've been doing our overdose reversal trainings and distribution of kits since 2006, 2007. Next slide. We do case management through all of our services. Next slide. We have a post office because with our mailing address, folks can't access public benefits. So we have about 3,000 to 4,000 people currently using our address for a mailing address. Next slide. We do a police assisted diversion program where we work with the police department to give people with low level, nonviolent offenses a chance to work with case management instead of getting locked up. Next slide. We work with universities like Penn, Drexel, and Temple to provide acute medical care. Next slide. We have 2 respites that house about 30 people apiece, and they're definitely actually more like 60 people apiece, and they're a gateway to folks getting permanent housing. Next slide. We do a ladies' night, currently on hiatus, but a specific drop-in center for the ladies. Next slide. We have an HIV specific clinic. We do wound care specific clinics. We have primary care. We have our own medication assisted treatment program. And we work with people to make sure that they have many opportunities for a mobile MAT as possible. Next slide. We work with many city partners, including the AIDS Law Project. We do a public restroom program. We help people with ID and other public benefits. Next slide. And we are deemed essential. We have not closed our doors. Next slide. Next slide. We know that language matters, so we don't use words that are damning to folks. If it's negative, we don't want to use it. Next slide. You can just go through these. Next slide, next slide, next slide, next slide. That's our location in Kensington. Next slide. And that's my contact information. Tried to put a lot, and unfortunately I talk too much, but hopefully folks will get the point. Anybody that wants to contact me, please email me, please give me a call. And thanks for allowing me to speak about what we do at Prevention Point.
You guys do really great work. Thank you so much. I want to turn to Tulsa. And I want to ask you guys a specific question. Either of you, Andrea or Hailey, can answer this, but can you tell us some successes your clients or your staff have had during COVID, some of the things you've done that have worked or that you're most proud of?
I'll go ahead and start that one out. So I would like to say that the first thing that we're proud of is we have been doing a delivery-based operations since we started in 2018. We do not have an office. We don't have a home base that we work out of. So we work out of our cars. We work out of our homes. And so we've been doing the delivery-based for syringes and other sterile items for people who inject drugs we've been doing that since the beginning. So that's something that we've really been proud of being able to pull off in Tulsa. And then the other thing is we started out only mailing out about 5 kits a week to people. And once COVID and our quarantine started at the end of February, beginning of March last year, we saw an increase in our mail-based outreach by 500%. So we definitely reach a lot more people now by that. We had a lot of regular every week participants that we started mailing to instead of meeting them out in public, but we also do a lot of porch drop-offs. As Hailey touched on earlier, we definitely miss the contact with our participants. We need it as much as they do. And so that's been really hard not to see them, because we've gotten close to some of them over the last couple of years. We've seen them, twice a week for the last 2 years. And so we worry about them when we don't see them. We wonder what's going on. And it's just really difficult to gauge that.
Right. And I think some other successes that we've had is we have been working with mutual aid organizations all over the city, really fighting for people experiencing homelessness and people who use drugs. Our outreach workers have started doing syringe services at a Food Not Bombs meeting every week, where people get access to free clothes, free food. And at this point, people experiencing homelessness are getting access to hotels and shelter. So that has been really exciting. And some other things that have been really positive for us during COVID-19 is, one, we have expanded funding for naloxone services. So that's helping us keep that mail-based program going. And then additionally, I just forgot what I was going to say, but basically there are a lot of positive things going on here in Tulsa, but there are definitely some negatives. And what I'm most proud of is the SHOT staff and the OKRA staff they're just showing up for people relentlessly. And so that's been something cool that we've seen this year.
Thank you, guys. One question I want to throw out, and I'll throw this out to you, Susan, although I'd like to hear everyone's thoughts on this, is, one of the things that COVID has done has changed some of the regulations. And I'm saying you, Susan, just because I know the MAT regulations better than others. I wonder if all of you have some ideas of whether there's something you'd like policymakers either to continue that they've done or would like them to do different the next time something like this comes up.
Yeah, I'm sorry. I do like that patients have been able to get more take homes so that they're not all coming in and exposing us more. And we haven't seen a lot of problems with it. It gives us more where the facility ourselves gets to determine maybe this is a better thing for that person, because they're not coming into the clinic. They're not seeing maybe some triggers and people that maybe are dealing, etc. So that I do like the takeout situation. I do worry that some facilities just blanket give them to everybody. So I there's the issue behind that, but I do like the takeout issue.
Other policy ideas people have?
If I could just add, not so much on the policy side, but the programmatic side, I think that a lot of harm reduction is siloed, as in it's only for people who use drugs. But I think a lot of the data that we shared today is that it's people who use drugs, who are also poor, who are also unsheltered. So we really need to look at programs that are more integrative, if you will, in terms of being able to challenge ourselves to meet people where they're at in the myriad of needs across different sectors. And the other thing that's really important, I really think we need to look at safer consumption facilities, safer injection facilities as spaces that, despite the physical distancing with COVID-19 that's required, could have provided a lot of that 24/7 service provision that became and is so critical for people who use drugs, who don't have a house, who don't have a home. And so I really think that we need to look at policy-wise at the creation of safer consumption facilities and really fight back against NIMBY and the not in my backyard movement.
Clayton, did you have something you want to say about policy before?
Yeah, I think that the policy of using more telemedicine for those who have access to technology has been a really big deal for a lot of us, especially with our medical clinics, obviously. And I hope that that's something that they will continue to do. I mean, I know that there's a major gap with technology, so it doesn't fit with everyone, but like many other chronic medical conditions, I think access to treatment should not necessarily be based on the ability to, attend every meeting or be viewed as, actually like observed every time something happens. I'd much rather someone get a, virtual, take home of, methadone. If it's a methadone program, we do Suboxone and now Trexone / Vivitrol. I'd rather folks not be seen, get the medication so they can use it, even if they're not, screened or anything, in place of them going out on the streets and taking, unknown, quantities of fentanyl and other additives that could kill them. At least if they're getting medication-assisted treatment, in particular from a pharmacy, it should be of the same grade and the same quality, and you can monitor, in different ways. So I would definitely think that's something I hope continues.
Thanks. Hailey, tell me something that you think your program would like to continue post-COVID.
What we're going to continue to do regardless of the pandemic is meet people where they're at. And the biggest thing that we are working on here in Oklahoma, harm reduction services are currently not legal. We have 2 bills on the House and the Senate. We have House Bill 1005 and Senate Bill 511 that aim to decriminalize syringe services programs. So that's really what we're focused on here at Okra and Shots in 2021. And the thing that we will never change is just showing up as our authentic selves, meeting people where they're at, and trying to end the war on drugs and end the disastrous effects that it's had on BIPOC in Oklahoma.
I know we're running out of time. I want to throw one more question out that you guys might. Do you find any particular issues related to working in rural communities? Sitting here in New York City, it's so different to us.
Yeah, it's really hard for us to get out to as many rural communities that need us around Tulsa and all of Oklahoma, because we are the only harm reduction program in Oklahoma. So we get messages constantly from people in other cities and other towns and asking us to come out and help or do things. And we just don't have that capacity yet because we're trying really hard to just serve Tulsa right now with our syringe service program. That's why we started OKRA, the Oklahoma Harm Reduction Alliance, so that we could venture out further into Oklahoma and start bringing better harm reduction practices to all of Oklahoma so that more people can start syringe service programs in these smaller areas that we can't necessarily reach. So that's another one of our goals as well, just to teach people how to do what we did. And honestly, when we started talking about doing a syringe program here, I started reaching out to people in the community, harm reduction community, and all they told us was just get some syringes and start handing them out. And it's illegal. I mean, it's technically not legal here. It's in a gray area with our paraphernalia statute, but we just do what we do because we know it needs to be done. So
that's really terrific. Susan, can you give us like a real quick sense of what it's like to work in rural areas down in Alabama? You're muted, but I could see your eyes rolling.
I even tried to put campers up to try to help people during COVID, and I was warned that they would put me in prison. And as for needles, if we tried to walk around with them, they would, I would drive a black Jeep and a lot of music going on when I'm driving, so they know me. But I would, we could not have needles in our car. They would arrest us, and it's very hard. We only have 20 methadone clinics in Alabama, and the law says we can't have any more unless it's all these crazy rules. So, it's going to take time to get some of these good old boys out of Alabama and let them kind of sadly die out, and just get more education in Alabama is what we need. It's really sad.
No, I hear you. We're at time. This was really, really terrific. I have to say, I'm always struck when I talk to harm reduction folks that you guys are all the real first responders in the opioid epidemic. And I have to say, in the midst of COVID, the agencies and the individuals that I know, I'm really amazed at how quickly people pivoted to providing services. You know, the idea of meeting people where they're at, when the where they're at changed dramatically, it was really harm reduction programs that completely changed their operations in an hour and were suddenly doing things while the rest of us were like, wait, what's going on? And it's really impressive. And I really appreciate the time you guys have all taken, not just in this webinar, but to prepare and put all this together. I could talk for hours. I mean, but that the world doesn't work that way. So thank you so much. I hope we'll have other opportunities to hear from you guys again and to support and learn about your work. Celia, do you want to say anything as a closing?
Just another thank you to Andrea, Hailey, Susan, Clayton, Tamara, and to Lloyd. This was so not only informative, but moving. And I think it makes us think about the relationship, especially between law and justice, and the kind of work that you're trying to do. And so I think we've all learned a lot and are greatly appreciative of this talk, as well as all the work that you're doing. So thank you. And I hope we will all be in touch in the future with future engagements. And if there's anything that we at Fordham can also do, you know, in terms of our center, both local or nationally, or the Institute, please don't hesitate to contact us, because, you know, sharing should go all around.
Thank you so much. Bye, everyone.
Bye, everybody.
Thank you so
Everyone.
much.
Bye.